Radio, I think we'll start in a minute or two. Okay, so my name is Dory. I'm one of the neurology co-leads at Mind the Bleep for the UKMLA Finals Series. Today we'll be discussing epilepsy, specifically the recognition and management of common seizure types. Epilepsy is a common neurological condition encountered across multiple specialties, including general practice, emergency medicine, acute medicine, and of course, neurology. Not to provide an exhaustive review of epilepsy, but rather to focus on the key principles required for clinical practice and the UKMLA. So in terms of our learning objectives, I've outlined these on this slide. So firstly, we'll clarify the difference between a seizure and epilepsy, which are related but distinct concepts. Then we'll discuss the approach to a patient presenting with a first seizure, including key aspects of the history and investigation. We'll look at both generalized and focal seizures. Within generalized seizures, we'll focus on tonic-clonic, absence, and myoclonic seizures. And then we'll consider focal seizures according to the lobe of origin. And finally, we'll discuss the acute management of status epilepticus and conclude with practical considerations such as pregnancy counseling, safety advice, and driving regulation with epilepsy. So we'll start off with sort of the approach to first seizures. So when assessing a patient who may have had a seizure, the most important aspect of the evaluation is the history. In particular, we're interested in the semiology of the event, which refers to the observable clinical features of the seizure. Ideally, the history should include a witness account, as patients often cannot recall the event themselves. Increasingly, patients or family members may have recorded the event on a mobile phone, which can provide extremely useful diagnostic information. So when taking a history, it's helpful to structure it according to what happened before, during, and after the episode. So for before the episode, we consider possible triggers like sleep deprivation, alcohol consumption, recent illness, head injury, and so on. During the event, we look for features that suggest epileptic activity, like tonic stiffening, rhythmic clonic jerking, tongue biting, loss of awareness. After the event, we ask about the postictal phase, which might involve confusion, headache, disorientation, fatigue, and so on. The next step is to determine whether or not the seizure was provoked. So provoked seizures occur in response to an acute disturbance of brain physiology. So for example, hypoglycemia, electrolyte disturbances, intracranial infection, alcohol withdrawal, or stimulant use, so stimulant narcotics like cocaine and methamphetamine, recent head trauma and medications, in particular the sort of neuroleptics and antipsychotics, and tramadol, which both lower the seizure threshold. So once provoked causes have been considered, we should sort of undertake investigations to support the diagnosis and identify any underlying pathology. So patients with a suspected first seizure should be referred urgently to a specialist, typically within 2 weeks. Blood tests are performed to identify metabolic abnormalities. A lactate's sometimes done to decide on whether or not this seizure was organic or psychogenic, but it's difficult to differentiate between the two with just a lactate. ECG has to be done for every single seizure, and that's to exclude arrhythmias that might present as a transient loss of consciousness. An MRI brain is used to identify structural pathology like tumors or vascular lesions like arteriovenous malformation. EEG is done for every patient, and that might demonstrate epileptiform activity to support the diagnosis. I think around 50 to 70% of patients have positive EEG, but that obviously means that a minority don't. And it's important to emphasize that a normal EEG does not exclude epilepsy. And in some tertiary centers, you might also have video telemetry where the patient's being filmed as they have a seizure and as the EEG has been recorded. And that allows for sort of classification of the seizure. Finally, we should consider sort of seizure mimics, so conditions like transient ischemic attacks or TIA, psychogenic non-epileptic seizures or non-epileptic attack disorder, dissociative episodes, migraine, vasovagal syncope can all resemble epileptic seizures. And distinguishing between these conditions is a critical component of the clinical assessment. So it's useful to clarify the distinction between a seizure and epilepsy. So a seizure is defined as a transient occurrence of signs and symptoms caused by abnormal, excessive, synchronous neuronal activity in the brain. So in other words, it's a single event. Whereas epilepsy, in contrast, is a chronic disorder characterized by a predisposition to generate recurrent seizures. So the International League Against Epilepsy defines this as either 2 or more unprovoked seizures occurring more than 24 hours apart, or a single unprovoked seizure with a high probability of recurrence. So this distinction is clinically important because a patient might experience a seizure due to an acute reversible event such as hypoglycemia or alcohol withdrawal without necessarily having epilepsy. And then sort of to round up the definitions, we'll look at generalized versus focal seizures. So seizures are broadly classified according to their site of onset within the brain. Focal seizures originate from a specific region of cortex, which is the sort of most superficial part of the brain, I suppose. The symptoms therefore depend on the function of that region. For example, seizures arising from the motor cortex, as in frontal focal epilepsy, might produce jerking movements, whereas seizures arising from the visual cortex and the occipital lobe might produce visual phenomena. Generalized seizures, on the other hand, involve bilateral brain networks from the outset. So in these seizures, both hemispheres are engaged almost immediately, and that's the distinction, really. Focal seizures can generalize in some cases, so it's important to be aware of that too. A small subset of patients will have an unclassified or unknown onset type. And another important concept is that seizures are stereotypic. So the same patient tends to experience seizures in the same pattern each time because the abnormal electrical activity spreads through the same neural network. And what this is relevant because if you have a patient who presents with multiple different sort of seizure semiologies, it's less likely to be a seizure and more likely to be something else. But, you know, seizures can evolve with time, depending on the cause. So now we'll consider the major types of generalized seizures. So as I mentioned earlier, tonic-clonic, myoclonic, and absence. Although that list isn't exhaustive, but just for the purposes of this. So tonic-clonic seizures. So these are the most recognizable seizure type and are often what people imagine when they think of epilepsy or seizures. So the characteristic features include a sudden loss of consciousness, generalized stiffening, followed by rhythmic jerking, and during which you might have some lateral tongue biting and post-ictal confusion. The seizure typically begins with the tonic phase, where you have sustained muscle contraction and generalized stiffening of the body. Sometimes patients might let out an epileptic cry, and then they collapse and lose consciousness. And this is followed by the clonic phase, in which rhythmic jerking occurs due to alternating contraction and relaxation of the muscles. During the seizure, the patient may become cyanosed due to impaired ventilation, and urinary incontinence may occur. With the breathing, you tend to breathe heavily and quickly, as opposed to shallow breaths similar to a panic attack. Lateral tongue biting is a particularly useful or helpful clinical sign, as it suggests an epileptic seizure rather than syncope. Following the seizure, there's usually a post-ictal period, and this can last between minutes and hours, during which the patient might be confused, disorientated, drowsy, and fatigued. From a sort of epidemiological perspective, tonic-clonic seizures can occur at any age and may form part of a genetic generalized epilepsy syndrome. They may also occur secondary to structural brain pathology like vascular lesions, trauma, tumors. The investigations are the same as I mentioned earlier. And sort of the aim is to identify the underlying cause and support the diagnosis. Management-wise, so this depends on the underlying sort of diagnosis. If you confirm epilepsy, then per NICE recommendation, and the guidance is NG217, the recommendation is first-line monotherapy with either lamotrigine or levetiracetam or sodium valproate. All medications have side effects. The main ones that come up in exams are that valproic acid or sodium valproate is a teratogen. It can also cause weight gain, tremor, and so on. Lamotrigine carries a risk of Stevens-Johnson syndrome if you titrate the dose too quickly. And levetiracetam is widely used, but might cause mood disturbance and irritability. Myoclonic seizures are sort of generalized seizure. These consist of brief shock-like jerks of the muscle. Typically, these jerks are bilateral and frequently occur shortly after waking. And as a result, sleep deprivation is a well-recognized trigger. Patients may report dropping objects in the morning because of these sudden movements. Awareness is usually preserved, meaning the patient remains conscious throughout the episode, unlike generalized tonic-clonic seizures. And many patients with myoclonic seizures also do experience comorbidly these generalized tonic-clonic seizures as part of a larger genetic epilepsy disorder. These seizures most commonly occur in adolescence and are most commonly in exam questions associated with juvenile myoclonic epilepsy. The EEG will show polyspike and wave discharges, and brain imaging, typically MRI brain, is usually normal because there doesn't really tend to be a structural cause. Management, again, is monotherapy, so it's either sodium valproate or levetiracetam. It's important also to recognize that certain medication myoclonic seizures, particularly carbamazepine, phenytoin, and lamotrigine, although you might see the latter being used in certain cases. But for exam purposes, it would be the sodium valproate or levetiracetam. The last of our generalized seizures are absent seizures, which are characterized by sudden, brief episodes of impaired awareness. Clinically, they present as episodes in which a child sort of abruptly stops what they're doing, stares ahead, and becomes unresponsive. The episodes typically last between 5 and 15 seconds, and recovery is immediate with no post-ictal confusion. And that's important when comparing it to focal awareness impaired seizures, but I've got a slide on the difference between the two later on. So these seizures may occur many times per day and can significantly interfere with learning and concentration. A notable feature is that absent seizures can be provoked by hyperventilation, which is why provocation testing for these type of seizures involves hyperventilation during EEG and video telemetry. Absent seizures usually begin in childhood and occur more commonly in girls, and the EEG findings highly sort of characteristic and shows a 3 Hz generalized spike and wave pattern. Treatment-wise, first line as a monotherapy is ethosuximide, and alternatives either as monotherapy or as add-ons include sodium valproate, lamotrigine, and levetiracetam. And again, carbamazepine, oxcarbazepine, phenytoin, etc. should be avoided as they may worsen absent seizures. There's on the NICE guidelines, there's a full list of anticonvulsants or anti-seizure medication that should be avoided in each specific type of seizure. So we'll go on to some questions. I'll read the question out and then I'll give you a few minutes or a few seconds rather to sort of answer, and then I'll go through the answer after the time has elapsed. So the first question is, a 10-year-old girl presents with sudden brief episodes where she stops speaking and stares ahead. These episodes last around 10 seconds and occur several times per day. She immediately resumes the activity afterwards and is unaware that they occurred. Neurological examination is normal. What is the most appropriate first-line treatment? So I think that's enough time. The correct answer is ethosuximide, as we saw on the last 2 slides. So the prompts in this question last very briefly, so a few seconds. They occur several times daily, and she's got no postictal phase, so immediately resumes activity and is unaware that they occurred. So for the next question, a 19-year-old university student reports sudden brief jerks of both arms shortly after waking in the morning. He has dropped objects several times rather. Last week, he had a generalized tonic-clonic seizure after staying up late studying. Which condition best explains his symptoms? I'll give you a few seconds. So the correct answer is juvenile myoclonic epilepsy or myoclonic seizures would be probably more correct. The clues are brief jerks in the morning, and he'd been staying up all night, and so he was sleep deprived. Next question. A 28-year-old man presents after a witness seizure. He suddenly lost consciousness, developed generalized stiffening, followed by rhythmic jerking of all limbs. The seizures lasted approximately 2 minutes. Following the event, he was confused and drowsy for 30 minutes. Which feature most strongly supports a generalized tonic-clonic seizure rather than syncope? So the correct answer is lateral tongue biting. So loss of consciousness, urinary incontinence, and limb jerking can happen in both syncope and seizure. Pallor before the event is more associated with vasovagal and cardiogenic. Lateral tongue biting is specific for epilepsy or seizures. Apical tongue biting, however, might present in both syncope and psychogenic seizures, so the location of the tongue biting is important. So we'll now move on to focal seizures. And as I mentioned earlier, this is where the symptoms sort of depend on the cortical region involved. So an important sort of distinction is aware versus impaired awareness when referring to focal seizures. So aware seizures were previously termed simple partial, and impaired awareness were previously sort of called complex partial. In focal aware seizures, the patient remains conscious throughout the event, and they don't have a postictal phase. In focal impaired awareness seizures, the patient becomes convulsive. Both seizures can evolve into bilateral tonic-clonic seizures, or bilateral or generalized seizures rather. So we'll go by lobe. So frontal lobe seizures, to start off with. These often present with prominent motor. Frontal lobe contains the motor cortical areas. These seizures are typically brief and may involve asymmetric tonic posturing, complex motor behaviors like cycling or rocking, or moving about really in an odd fashion or semi-purposeful fashion. And sometimes they also have vocalizations like crying or screaming. So they frequently occur during sleep and may therefore be mistaken for parasomnias. Hypermotor behaviors like rocking or cycling can also occur because of activation of the motor regions, including the supplementary motor area, the motor cortex, and the premotor area. And first line for focal epilepsy in general is a monotherapy of either lamotrigine or levetiracetam, and failing that, a monotherapy of either carbamazepine, oxcarbazepine, or zonisamide. And at the top, I forgot to mention, we've got some sort of buzzwords for exams. So Jacksonian or motor march, nocturnal, they might be screaming. And one thing I also didn't mention was that there's a rapid recovery, but you might have Todd's paresis, where you have focal neurological deficits to the region affected during the seizure. So next up is temporal lobe seizures. So this is the most common form of focal epilepsy, and typical features include auras, like experiential ones, like déjà vu, so a feeling of having experienced something before, and jamais vu, which is a feeling of never having experienced any sort of a familiar event. Fear, epigastric rising, and less commonly, auditory, gustatory hallucinations. As the seizure progresses, awareness may become impaired, and automatisms like lip smacking might occur, and these are sort of semi-purposeful movements, and you will have postictal confusion in most cases. MRI may reveal mesial or medial temporal sclerosis, and this is a condition that sort of involves hippocampal damage. It might occur following childhood febrile seizures caused by roseola, which is caused by HHV6, or other hippocampal injury. CNS infections by herpes simplex virus 1 causing an encephalitis will also potentially trigger focal seizures. Investigations are the same as all other seizures, but on an MRI brain, you'll see mesial temporal sclerosis. And in the case of HSV1 encephalitis, you might see bilateral hippocampal petechiae if there is an infection. And much like the other focal epilepsies, first-line monotherapy and second-line monotherapy is the same. So lamotrigine, levetiracetam, first line, and then second-line carbamazepine or oxcarbazepine or zonisamide. So I've grouped the last two together just because there's not really much to say about them and they're quite rare. So parietal lobe seizures typically produce sensory symptoms, so parietal paresthesia. So these might be tingling, numbness, or a sensory march in which the abnormal sensations spread across the body in a similar way to the Jacksonian march, except this time it's sensory and not motor. Occipital lobe seizures produce visual phenomena because of the occipital cortex is where the epileptic discharges are originating, and this is the part of the brain that processes visual information. So patients might describe simple or complex visual phenomena, so things like flashing lights, colored shapes, or sometimes visual hallucinations. In some cases, seizures, as in all focal epilepsy really, may spread and produce a generalized tonic-clonic seizure, and management again is the same. So we'll go on to this sort of comparative table. I'm not going to run through it. It's just for reference, but it sort of summarizes everything that really needs to be known for the UKMLA and for sort of clinical practice at an F1 level. And like I mentioned earlier, the difference between focal and absence. So absent seizures are generalized seizures, whereas focal seizures with impaired awareness are focal seizures. In terms of frequency, absence occur multiple times daily, and focal seizures are much less frequent, occurring several times per month. Absent seizures tend to last less than 30 seconds, so they're very brief, very quick. There's no postictal state in absent seizures, whereas there might be in focal awareness impaired, alongside automatisms. We'll go on to our next set of questions now. A 32-year-old woman experiences episodes lasting 1 to 2 minutes, where she develops a sudden feeling of fear, followed by a rising sensation in her abdomen. During the episode, she smacks her lips repeatedly and appears unresponsive. Afterwards, she is confused for several minutes. Which brain region is most likely to be involved? So the correct answer is the temporal lobe, and the clues are the sudden feeling of fear, the rising sensation, and I've not highlighted this, but also the unresponsiveness. The next question, a 24-year-old man reports brief episodes during sleep where he suddenly sits up and performs rapid, bizarre movements of his arms and legs. The episodes last around 20 seconds and he recovers immediately. Which seizure focus is most likely? So the correct answer is frontal lobe. Again, these are hypermotor seizures that tend to occur coming out from sleep or during sleep. So we've got the during sleep here, rapid bizarre movements and immediate recovery. The last question for the focal seizure portion of this talk. A patient reports episodes of flashing colored lights in the right visual field lasting around 20 seconds. Awareness is preserved. The symptoms occasionally progress to a generalized tonic-clonic seizure. Which seizure focus is most likely? So the correct answer is the occipital lobe. Again, this is where the visual cortex is. If you have visual symptoms, it'll be the occipital lobe. So we'll now move on to the final portions of this talk. So we'll go on to the acute management of status epilepticus, and then we'll look at pregnancy, driving, and general safety advice. So status epilepticus is a neurological emergency, and it's defined as a seizure lasting longer than 5 minutes or recurrent seizures without recovery between episodes. There are 4-ish steps to managing status epilepticus. So you'd start off with an A to E assessment, including oxygen administration, gaining IV access for future drug administration. You'd check capillary glucose or BM. And if hypoglycemic, then you would give IV glucose 10% at 200 mils or 20% at 100 mils. And of course, with any sort of medical emergency at F1 level, you should escalate to a senior. At 5 minutes, if there's no termination of the seizure spontaneously, then you would administer benzodiazepines, which is a type of medication that dampens down neuronal transmission. So that there are multiple options here depending on your location. So in a hospital where you have IV access, you might elect to give lorazepam 4 milligrams as an IV bolus. In the community, you might see buccolam being given, which is buccal midazolam. So it's a sort of gel that you put between the gums of the gums and the lips of the patient, or less commonly diazepam per rectum, and you'd wait for a few minutes. If that hasn't terminated after the first dose, you can give a second dose. Now, if the seizure persists after 2 doses of benzodiazepines, you'd need to use second-line anti-seizure medications. So that includes levetiracetam IV, phenytoin IV, or sodium valproate IV. Levetiracetam is mentioned in the NICE guidelines, but it's unlicensed. But you'll often find it being used in clinical settings. Failing sort of anti-seizure medication administration, this would now be sort of refractory status epilepticus, and you would need to call sort of the anesthetics registrar or consultant at your hospital and put in an urgent intensive care unit referral. In the intensive care unit, they might do things like rapid sequence induction, give them anesthetic agents, and intubate and ventilate them because their airway will be compromised. So anti-seizure medication, there are lots of them, and they come with sort of side effects that are commonly tested in exams, even outside the sort of obvious epilepsy questions. So I've listed out the most common ones, again, for an easy sort of table to refer to. So the main things to consider are that sort of lamotrigine has the rash risk, and you have to titrate it slowly. It's safe in pregnancy relative to valproate, but it does interact with oral contraceptive pills. So the oral contraceptive pill will lower the bioavailability of lamotrigine, so you might need higher doses in patients taking oral contraceptives. Levetiracetam is very commonly used. The main side effects are mood changes, irritability, depression. There are some second-generation anti-seizure medications like brivaracetam, which is in the same class, that don't have these symptoms, so you might see these being commonly used. Sodium valproate is probably one of the most famous anti-seizure medications. It can cause weight gain, tremor, hair loss, and thrombocytopenia, so low platelet counts. The main sort of exam point, I suppose, is that it's a teratogen, so it can cause neural tube defects and neurodevelopmental delay, and you should avoid it in women of childbearing age unless they're on the pregnancy prevention program. Ethosuximide is used in absences, GI upset, and fatigue, quite non-specific side effects. Carbamazepine is used as an alternative medication in focal seizures and can cause hyponatremia. It's also a P450 inducer, so that's important to recognize in pharmacology questions. Oxcarbazepine is similar to carbamazepine, and phenytoin can cause gingival hyperplasia, so swelling of the gums, ataxia, and neuropathy. It's got a very narrow therapeutic index, meaning the dose where it's therapeutic and toxic is quite slim. And again, it's also a P450 inducer. So it will reduce the efficacy of drugs metabolized by the CYP450 liver enzyme. So to finish off, we'll go through some general points about pregnancy safety advice, the DVLA in the context of epilepsy. So sort of driving wise, after a patient had a seizure, they have to inform the DVLA and they have to stop driving. So if they've got a Group 1 license, which means they drive a car or a motorcycle, they can't drive for 6 months after the first unprovoked seizure. And if they subsequently receive a diagnosis of epilepsy, they have to be seizure free for 12 months before driving. The reason for all this is that to have epilepsy, you must have a predisposition to having seizures. And so that's why it's a bit longer, because you're more likely to have seizures than if you've just had a one-off. If you have a Group 2 license, the restrictions are between 5 and 10 years. They're much stricter than Group 1 because obviously a truck or a bus is going to do more damage than a car or a motorcycle. Some things to consider: so breakthrough seizures, reset driving restrictions, and medication adherence is essential. So and that can change. So you should not drive for 6 months, or a patient should not drive for 6 months after medication withdrawal, even if they haven't had seizures in a while. Pregnancy wise, so the preferred medications are lamotrigine and levetiracetam. Sodium valproate is highly teratogenic. It can cause neural tube defects, other congenital malformations, and neurodevelopmental delay. And it should be avoided, like I mentioned earlier, unless a woman of childbearing age is on the pregnancy prevention program. In terms of preconception advice, folic acid, 5 milligrams as opposed to 500 micrograms is recommended, and that's prior to a medication review might be done by a neurology consultancy, and monotherapy is obviously preferable to multiple different anti-seizure medications. It's crucial to sort of say that anti-seizure medication should not be stopped if a woman is pregnant, because that risks breakthrough seizures. And then general safety advice that you might counsel patients on if you see them in ED with a single sort of provoked seizure, or if you're in clinic and your consultant asks you to counsel somebody who's just been diagnosed with epilepsy. So avoid swimming alone for obvious reasons. If you have a seizure in a swimming pool, you're at high risk of drowning. And for the same reason, showers are better than baths. Avoid heights and climbing. Take care with cooking and open flames. And a ketogenic diet might sometimes be recommended, particularly for juvenile epilepsy that is refractory to multiple different types of anti-seizure medication. In terms of lifestyle measures, maintain good sleep, avoid excess alcohol, take medication regularly, i.e. your anti-seizure medications. And it's important also to note that epilepsy isn't benign condition or an inconvenience. SUDEP is a sort of not so much a common occurrence, but an occurrence nevertheless. And the risk increases with poor seizure control, and so you must emphasize adherence and attending follow-up. So we've got our last few questions before closing. So the first one: a 26-year-old woman with epilepsy attends clinic to discuss pregnancy planning. She currently takes sodium valproate, and she last had a seizure 5 months ago. What is the most appropriate advice? So the correct answer, correct answer is switch to lamotrigine or levetiracetam if possible. So sodium valproate is a teratogen. Stopping it immediately would be unsafe, given that she had a recent seizure. Reduce the valproate dose. Again, it's a teratogen. and add folic acid 400 micrograms daily is correct in a sense, but the dose is too low. So it would be 5 start pre-conception. The last question, a 34-year-old man experiences a first unprovoked generalized tonic-clonic seizure. Investigations are ongoing. What advice should he be given regarding driving? So correct answer is stop driving for 6 months. And it's because it's the first unprovoked seizure. It would be 12 months if he'd had seizures in the context of an epilepsy diagnosis. 3 months is too short, and driving restrictions do apply from the first seizure, not only if epilepsy is diagnosed. So that concludes the talk today. I'd be happy to take any questions. I'm periodically looking at the chat on YouTube, but I'm happy to take questions in the future via my email, which is on screen now. I'd be really grateful if you could leave some feedback. There's a link in the YouTube sort of bio caption. And yeah, so I'll wait around to see if anybody has any questions. And to make it a bit easier, in the top left corner is the feedback. There's a QR code linking to the feedback form. Okay, so I think I'll call it a day there. Like I said, please fill out the feedback form. It helps a lot with future sessions. There's a QR code in the top left-hand corner. And if you have any further questions about the talk today, I'll happily reply via email. Thank you all for attending.